Myself in place one.
Yeah. I don't know if anybody's sitting here, Dan. Let me find that.
We're good.
Okay.
Oh, I'm.
All right, we got.
gonna be trained. I can fly really well.
Yeah. Okay, Andy knows we're starting. Is everybody got it? Everyone's got there? Okay, did everyone get some dessert? You can't wait till it's all gone, you know that. Well, you got the best seat in the house there. All right, well, welcome, everybody. I'm Rachel DeGolia, your hostess this evening. And we're so happy to have everyone here. And so what we like to do when we start is just very quickly go around the room and everyone says their name and one thing about themselves, like if you're a student, where you're a student, etc. I am retired, but I used to work for the Universal Healthcare Action Network. So I have a big investment in health issues. So we'll
Go that way.
go that way.
Judy Carver, retired mental health nurse, and community health was my thing.
I'm Kate. I'm a resident at Metro. I'm Rachel. I'm a M1 at Case.
I'm Joan Trey, I'm a retired hematologist oncologist.
Willie Katzen, I'm a retired pathologist and facilitator in IQ.
Dan Brustein, a mostly retired occupational medicine physician.
Ann Reichsman, retired family practice from neighborhood family practice.
Okay, let's do this and then we'll go in the back. Yeah.
Michelle Beasley, retired Metro health doctor, 30 years.
Yeah. Nathan Beachy, retired family medicine Metro.
We'll come back to that guy. Okay, how about here?
Nancy Lee, family medicine.
Not retired.
But hopefully by 40, I'm just kidding. She retired.
Nice.
I'm Lauren Bouchard. I'm an OBGYN at the Cleveland Clinic. Not retired.
I'm Dan Booth. I'm one of the neurologists at Metro.
I'm Emily. I'm an M1 at Case.
I'm Stan Wright. I'm M2 at Case.
I'm Marissa Luca. I'm M2 at Case.
I'm Mia. I'm also an M2 at Case.
Hi, I'm Isha. I'm an M1 at Case.
I'm Kurt, I'm a PGY 37.
Hi, everyone. I'm Zane. I'm an M2 at Case.
Hi, everyone. I'm Arohi. I'm an M2 at Case. Hi, I'm Shannon. Also M2 at Case.
All right, great. We were hoping some OU students were going to join us tonight, but maybe they'll still wander in here. So we'll see. So I think we have already started here. So I'm going to leave it to, introduce yourself, please.
Zoe Rose, M2 at Case.
Ken Frizoff, UCAN, retired family doc at Metro.
Okay,
And I get to introduce.
right. So we usually ask Ken or somebody, but often it's Ken, to give us a little context for a theme for the night, so we don't just jump in with the speaker right away. And then Ken's also going to introduce our speaker tonight too.
Well, I'm going to introduce the speaker first, and then I'll say
Okay,
a very few things. So David and I have known each other for over 30 years. And you might look at him and say, how did I know this guy? And the answer is that he was the older brother of a preschool carpool that had my son in it.
He always knew.
I always knew that someday.
Yeah, right.
Yeah.
there. Just a minute, let's get these guys some chairs. Okay, you came late, you gotta sit up front. Sorry. Yeah,
So the chairs I brought in were in your study back there.
well, there's a few chairs left in here, aren't there? Let's bring them in. Okay, how many are you? Three. Perfecto. Okay. I hope you're hungry because we have a lot of food left too, and dessert. Here, let's put one here. We can put one right here. Come on up here, guys. Yeah. And if you want to put your coats on the bed, it's not.
They'll sit at the
And someone can sit. Oh, there we go. Slide it.
Oh, that's a tall chair. Let's put this chair over. Oh, right.
Sorry.
Okay, that's good.
This all started.
Is it? It's really raining?
It's really raining out there.
If you want to get something to drink or some,
No, I remember.
just whenever.
I'll check that.
Okay, go ahead. Check it out. We got a lot of food in the other room.
Yeah.
It was raining.
Yeah.
Let's see.
Do you mind if I heard it? What's your preparedness now?
There.
Oh,
That won't affect me. because-
Right.
so Colin, you're,
I'm gonna just make sure everyone's sitting down and comfortable. And we'll go ahead. We were just doing introductions, so Colin, you want to introduce yourself?
Hi, my name is Colin. I'm a second year medical student at OUH Palm student campus.
And where's the other one? Oh, back there.
Hi, Jordan Drovely Bob again, also second year medical student in the TCC program at OU, and training as well.
Yes, she's a special breed, that one. Okay, and introduce yourself.
Hi, Chris May, second year at OUH Palm.
All right. Excellent. So Ken, take it away.
okay, so it's. When you're old and retired, you can say stuff like, it used to be different in the old days, and in the old days. Public health was really much more highly thought of and essential than it is now. I happen to be reading a book that a friend gave me about the 1853 cholera epidemic in London. And they did some remarkable science with no computers, very little stuff. And most of the advances in life expectancy and quality of life were a result of public health. And so it is great for us to have a public health leader here to talk to us tonight. And it's especially great because as public health, for a variety of political reasons, lost some of its punch, you sort of had two different worlds. You had the public health world and the practice of medicine world. And David is somebody who bridges both of those, as well as having a deep understanding of systems and system changing, how to change systems. So it's really exciting to have you here. And floor is yours.
Okay, thanks. Thank you. Thanks, everybody, for having me. And Rachel, I remember, okay, I knew that. All right. Rachel came, Rachel's heard all this before. She came to visit me at the health department. So yeah, thanks all for being here. My plan for the evening, and remind me, total time you want with discussion is?
Well, 2025 for
And plenty of time for
comments
Q&A.
and then about the same amount for discussion.
All right, so all right, good. Okay, so my plan is to tell you about my career, how I got, ended up doing whatever the heck I'm doing now. Tell you about what I'm doing now, what it means to be the director of public health, as much as I can tell in the first 6 months. And then pivot into what I think are kind of the 6 biggest issues, health issues in Cleveland. And with that, what we can all do about it. Does that sound okay? All right. Sounds good. Okay. Born in Cleveland, grew up in Shaker Heights, went to Brown for undergrad and med school. And I was in that, there's this program that is like 8-year program. So you already, you're in med school when you're in undergrad. So you're supposed to like do non-sciencey stuff in undergrad and avoid all the pre-med students. Highly recommended. Sorry that you're all together, but I really like science. I was really into emerging microbial diseases. And at the time, Paul Farmer was like becoming a celebrity. And so I was really inspired by that path. So started med school, really wanting to be one of these global health infectious disease doctors and like go and, save the world. As I learned more, about the world, learned how there were some problematic components to that. which if they're not obvious, I'm a white guy from Cleveland, and like, why should I be the one to like save, the world? That's pretty obnoxious of me. And so I learned a lot about that. And then started to learn more about the problems in Cleveland and in the United States. So I was starting third year med school, and we had this community health rotation. And I had been a volunteer at our free clinic, the Rhode Island Free Clinic, had been the volunteer coordinator at the free clinic. And so said, all right, this is where I'm going to do my rotation. All right, free clinic, like what's going on? What's your big challenge? And they said, we don't have enough primary care physicians who are volunteering at the free clinic. And I was like, well, why not? This is an amazing gig. Like, where are they? And so, Google it or Yahoo'd it or whatever we had at the time. And turned out there's this national primary care shortage, that this was brand new to me. I had, I thought I was pretty smart at, at this time, but had no idea. And so read more and more about the problem, read a lot of Kurt's work, kept coming across these two names from San Francisco, Tom Bodenheimer and Kevin Grumbach, who are, primary care physicians and thought leaders in San Francisco. And so realized that like I was just on this path, could keep going, and, saw what maybe that future looked like, but realized I wanted to take a step back and understand this issue better. Was frankly embarrassed that, I'd been through all this schooling and didn't understand how the healthcare system had de-emphasized and not supported primary care, and ended up with this upside down triangle where we've got all this investment in the hospitals and specialists and everything else, and very little and the stuff that matters most. So in terms of greater impact on health, I apologize for any specialists in the room here before. And so wrote to this guy, Tom Bodenheimer, and who like has written textbooks, just an incredible, person that's famous in this community, in the academic primary care community, and said, I came across your work. I'm really interested in this issue. I think I can get funding. And so I'd be free and could come work for you, for you for a year in San Francisco. I'll move out there. And he said, yeah, you're gonna, have funding, and absolutely, come on out. So I applied for funding and didn't get it. And then I wrote him back, had already packed all my bags and everything, and said, and I should say, pause there, but I told my med school advisors, hey, I'm gonna do this. I'm gonna take a year off and study with this person who they had. And said, I don't know, it doesn't look good on your resume, this year off. Unfortunately, I connected with this guy, Jeff Borkin, who's a Cleveland native and the chair of family medicine out there. And he's like, are you kidding? Like, don't come back, this is an incredible opportunity. So I wrote Tom back and said, I don't have funding anymore. I'm really sorry, but I'm still would like to come. Can you please pay for me? And he said, all right, how much money do you need? And I said, well, the funding that I applied for, and this is San Francisco, city of San Francisco, not too long ago, 2009. I said, the funding was for $28,600 for the year. And he said, yep, come on over. So it turns out, so he hired me as a research assistant, 0.75.
What year was this?
2009.
No.
And so, yeah, not enough money to live in San Francisco, it turned out. But so I was a 0.75 research assistant working full time. But it all worked out. We somehow, found an apartment for $600 a month the right before everything took off, and it is, that's a whole other story. But got to work with him, and the work that I got to do with him was on primary care health policy. So I got to work with the San Francisco Department of Public Health that runs their primary care network, figuring out how to improve all their primary care processes. I got to write papers. I got to present at national conferences. I met Kurt through that, actually, when he came out to San Francisco. That was when we first met. I met Don Berwick, who was the head of the IHI at the time. I met Nathan and Rochelle's cousin, Doug Eby, who runs this incredible healthcare system in Alaska. And so it was just, it completely launched my career. I published 12 publications and all this stuff. So launched my career. It was incredible. I stayed in San Francisco for residency, doing a primary care track for the underserved at San Francisco General Hospital in internal medicine, but I was always a family medicine groupie at heart. But just, growing up here, it's hard. It's family medicine, it's just in the West Coast, they like really cherish it more than, than they cherish here. So we're working on fixing that, but did that program, stayed on for a chief resident year and quality improvement and patient safety. They'd given me the option, be the primary care chief resident of this quality improvement and patient safety position. And I really wanted to focus on system improvement work, and such as the whatever ladder form or which one ever. So meanwhile, I'd met my wife in San Francisco the first week of residency. She was a research assistant and doing work on sugar sweetened beverage taxes. So really cool stuff. We're trying here, Ohio. So that's another story. We'll get there. And so by this time we were married. And my chief resident year, we got married the summer after graduation from residency. And she was 8 months pregnant, or she was pregnant, during this year. And we said, all right, where are we going to go? At this point, I realized like the work I wanted to do was on primary care systems improvement in the United States. But I was not thinking about Cleveland at all. I was thinking about like Austin and Portland and Seattle and all these very cool cities, And my wife, who is much smarter, than me, and if you've had the pleasure of meeting her, you know that she's originally from Ethiopia. She immigrated when she was 21 to San Francisco. She said, "What are you talking about? Cleveland is the most incredible place. Like the people are they stop to talk to you. They're so nice. Like you can make a difference there. You ain't shit in San Francisco, essentially, and you're just gonna, competing with all these UCSF people and, getting your name on papers, and who cares, so like, go to Cleveland, dudes, let's go. And so we didn't tell my parents, which, it's always cautious because I didn't want to tell them until it was like a done deal. I didn't want to get their hope. They never thought I was coming back. Googled, which hospital was the safety net system. Because again, didn't know. Metro Health popped up, reached out, basically cold emailed Metro Health and said, I'm looking for a primary care job. I want to be away from the hospital. I want to be in the community, and I want to be doing primary care. And so because of Tom Bodenheimer, who is my mentor, who has written all these books and papers and all this stuff, didn't start doing any of that until he retired from primary care after 30 years of primary care. So they were really confused with that, because most people who had been applying for primary care jobs around this time and to this day are like one half day and all these kind of block times and things like that. But we negotiated back and forth, and finally I got my wish and started at the Broadway Health Center, which is in the Broadway Slavic Village neighborhood here in Cleveland, over there in Cleveland. And 20% of my time was working for this regional health improvement collaborative called Better Health Partnership. They were like, I was like, all right, fine. Did that for a year, and then the same, unfortunately, Metro Health came calling and said, you got to move to main campus because we really need you to do this over here at main campus. And so sadly, and I was only internal medicine doc at Broadway, and I like confused everybody. So they got me out of there. But fortunately, a lot of my patients came with me, were really important to me. I should say, my first day at Metro Health, I met Ken, who was moving out of his office, left his wife go, gave me all his patients, and which was great. So moved over to main campus, and in my time there, I was the medical director of the main campus internal medicine practice. Then they didn't have, there was kind of back and forth focus on system quality improvement at that point, despite everybody's best efforts. And so I said, hey, I've got this experience. Let me run quality improvement across the outpatient system, and wrote a memo, which is a life lesson. If you write something down and hand it to people, they will sometimes more often say yes. So they said yes. So another 20% of my time was bought off. And then one thing led to another. I was, I think, interim division director for internal medicine. So it was over 60 physicians and nurse practitioners in internal medicine. COVID started. This is now March 2020. I've been there 5 years. And our CEO at the time, who you all know is a criminal, had made this proclamation that we were going to start this 24/7 COVID hotline, which was his leadership style. And honestly, it was effective. Like he would just say something and figure out how to get it done later. So nobody had any idea how to do that. So I said, yeah, I'll do it. Which is another life lesson, good or bad. And so stayed up for the next 2 years without sleeping and ran a 20, and then so stayed up for the next couple of weeks, but we launched this 24/7 COVID hotline that was really well received and needed by the community. I mean, at that time, at the beginning, we didn't have testing, we didn't have treatment. The only thing we could do was kind of help people decide whether or not they were sick enough to need to come into the hospital. And we did a really good job. We did a really good job of reassuring people, keeping people at home and helping people know the right time to go. And so that gave me a lot of media attention, I would say. So at the same time, Metro was kind of using me to do a lot of their local news interviews, which is another maybe life advice. Just say yes to those, because we're all bad at them at first, but you practice and you watch yourself and you ask for advice and try not to nod as much and you try and be more relaxed and all the different things that you can work on to get better. So I was doing all that. I became full-time division director. I became interim primary care director, which was over all the primary care, dentistry, and urgent care, and was applying for that job full-time. And then Mayor Bibb won the election. And I, in the back of my mind, was wondering how he would approach the searching for the director of public health. Didn't know him, had no relationship with him prior, and didn't really know anybody close to him. But the job got posted in April 2022. And at the same time, I'd been applying for this job at Metro for over a year, and which is just how things go sometimes. And the job got posted, and a couple friends nudged me to apply, and I applied. I had 2 interviews. The latter was with the mayor on May 23rd. They called me the next morning, May 24th, offered me the job. And I walked into, my boss's office at Metro and said, I am not running away from you. I'm running towards something. And I started my job as director of public health August 1st. And it's been great. So that's kind of how I got there. And, we can maybe, I don't know, should we pause there? And well, no, I'll just keep going. All right. So I haven't lost my voice yet. I'll keep going.
Do you need anything to drink? Go
I
sit
have
with me.
my
Okay, good.
Christmas ale.
Okay, good.
Yeah. So what does it mean to be the director of public health? Phase 2 of the talk. The Department of Public Health in the city of Cleveland has a storied history. A not good history. So there are basically 4 divisions: environment, air quality, health, and health equity and social justice. Environment does all state and local code enforcement. So that is all the restaurants, barbershops, tattoo parlors, pools, and local code enforcement means like if there's tall grass or trash or anything that can be deemed a public health nuisance. And then the most important part of environment, the most high profile part, is lead poisoning. So any child in the city of Cleveland who tests positive for lead poisoning above a certain level, that result goes to the Ohio Department of Health. Ohio Department of Health sends us a message, and our team goes to investigate where basically the child was poisoned. Most of the time the implication being in the child's home. And then there's a series of steps that one has to take to remediate the home so that it's safe to live in. That unfortunately are really hard to do, especially in a city like Cleveland. So that's environment. Air quality, we are the EPA for air for the county of Cuyahoga. So we do all the permitting for any kind of pollution, air pollution producing factory junkyard and all that stuff. So we do permitting enforcement, we do outreach. We have ambient air monitoring all over the county. And we're able to do some creative things there. We're doing a lawnmower rebate program where you can scrap your gas lawnmower. We'll give you a $100 gift card for an electric lawnmower. And coming soon, hopefully, we'll do that e-bike rebate like Denver.
Lawnmower stuff works great, by the way.
Yeah, the lawnmower stuff works great. Yeah. So you might not think lawnmower, how much pollution can be a lawnmower, but like cars are regulated. You go and do the e-check. But lawnmowers, there's no regulation. It's just. And so, even if we were to just focus on Solon, scrapping all their gas lawnmowers, that would help Cleveland because the air floats around. So that's, very exciting program. Right, electric lawn, maybe your point was electric lawnmowers work really well. Yes, that's awesome.
All right, and I like the rebate.
Okay. And then health, we run a couple clinics, we have vaccination programs, emergency preparedness and epi team. Health Equity Social Justice runs infant mortality reduction program through community health workers that are licensed through a bunch of community partners, HIV STI prevention program, and mental health and addiction recovery. So the history of the health department is, I should say let's focus on the last 10 years. Well, first of all, so there hasn't been a physician health director in 40 years. Hasn't really been a health background director, and we think probably around the same amount of time. The previous health director, who is, I'm told, was kind of the best, is this guy Matt Carroll, who was one of my friends who nudged me to do it, but he had come from kind of just being really good at government administration, and now works for the county government administration. So in 2015, right when I was starting at Broadway, and remember this vividly, it turns out the health department had a backlog of uninvestigated lead poisoning cases of children of 3,000. 3,000, and it wasn't the health department's fault alone. I mean, it was just across the board badness. And they cut funding across the country. I mean, bad things were going on, but it certainly, it was not a good look for the health department. Pretty much everybody got fired at the time. And so that was going on. And then a couple of years later, there was a declaration from the city that racism is a public health crisis. And the same writer who wrote all the stuff about the lead poisoning program is like my idol, Rachel Dissel, wrote this story in the Cleveland Scene called something like Racism Public Health Crisis, and there is racism in the public health department, or something to that effect. So really bad. So everybody got fired again. And then there was an interim director for 2 years. This wonderful man, Brian Kimball, who just comes through the environmental health world. And he was interim director for 2 years. So that was what I was walking into in terms of the work. The outcomes, I think you all know this, are that the Cleveland faces in terms of health, and we'll go into 6 specific things in phase 3. The life expectancy of Clevelanders is about 10 to 20 years shorter than life expectancy of not like Moreland Hills, like inner ring suburbs, like just right next door, 2 blocks away. And so huge problems. And Cleveland's Department of Public Health has just never, at least in recent memory, been at a leader at the table for these conversations. And correct me if I'm wrong, anybody. Right. And that's been a big problem. And the county has a better functioning health department, has always had, and the county's health department serves 57 municipalities in Cuyahoga County, the 58th being the city of Cleveland. So it's always been this weird dynamic. It's like, why don't you guys just merge? And the county was like, you don't want, we don't want your smoke, you don't want our smoke, that sort of thing. But the mayor campaigned on it, and so that was something that we explored, but we're not going to do it. But so that so they're going to want to merge with us. So that's what I walked into. But what the good news is, as I said, all these people got fired both times. And so the people who are left are incredible group of people. Brian, who officially is now assistant director, on down. I mean, it's just an incredible group of people who I think, have been happy to have a leader who is, ready to be at the table. And now some of these conversations have been difficult because I'll be at the table and they'll be like, where the heck have you been? Like, you haven't supported us over the last 20 years. I'm like, yeah, I know, I'm sorry. It wasn't my fault. But for the most part, it's been really nice. And much of it is, as through much of my career, it's just showing up with a memo, showing up with this might not be the best plan, but it's a plan. Let's work from this kind of thing. And so that's taken me a long way. So that's what the health department, those are the divisions and some of the work that we do in the health department. Let me now go into the 6 issues that are top of mind for me. So number 1, and this number 1 being number 1, so we'll come back to number 1. The number 1 issue for health in Cleveland that we can act on today is smoking. Cleveland has the highest smoking rate in the country at 35% of adults, which nobody knows. Nobody knows. I grew up in the 90s, and it was like we took care of, like what kid grew up in the 90s like is smoking, I mean, it's just, we all know it's bad, right?
I moved here from Minneapolis in the early 90s, and I was appalled, and I remain appalled. But I don't understand how nobody knows this, because it's like hit you over the
I
head.
agree. So yeah, exactly. I mean, you can really, if you go to other cities, like there aren't adults smoking everywhere, but in Cleveland there are. And obviously it's multifactorial, and we can get into all that kind of stuff. But that is an area where we can work on it. And so in your roles, when you're in the clinical areas, I mean, clinical folks, not everybody, but many of us, we kind of got burnt out asking people about smoking and our, the readiness to quit. So that's one area, just, a reinvigoration around every time, because it's, for most people, they want to quit. Most smokers want to quit. That's what the data shows. And B, as you've all heard, most people, it takes many times to quit. So we can talk all about that, but so we're going to hope to launch a mass media campaign with all our healthcare partners to kind of remind everybody and kind of get excited about this. And then probably the most important part of this, after we create the groundswell, the energy to address this problem as a city, and hopefully we can do that in the next 3 months, is we're going to hopefully pass some legislation that does 2 things. 1, tobacco retail license, which means if you sell tobacco in the city of Cleveland, you have to pay $500 a year. That $500 a year pays for enforcement of all the rules. The rules are: don't sell to kids, ID anybody under 30, and don't advertise in your windows. And we're going to add a 4th rule, which is don't sell flavored tobacco products. Columbus just passed theirs. The Ohio legislature quickly passed a law to make their local jurisdiction illegal, in terms of take away home rule. But then Governor DeWine, who's a huge anti-tobacco guy, one of his only redeeming qualities, vetoed it. And so they're going to try and get a super veto majority or super, whatever. But in the meantime, we're all going to try and pass these laws. City council has not really been at the table for these conversations. They're the ones that need to pass it. So one area where I really could use the help for anybody who lives in Cleveland, or even if you don't, the public comment window process during Monday night city council meetings are so effective. And I don't know if anybody here has done one, but there were a couple of case med students who did one a couple months ago, but just about universal health care. And, city council doesn't have the power to pass, universal health care, but it was just, when you're going up there and giving this testimony, I mean, every 17 city council people, the mayor, every chief director throughout the city is staring at you for those 3 minutes, no pressure, but you have their full attention. And it's a really powerful moment. The public comment in city council didn't exist until this year. thanks to some obstruction, preventing it from happening, but some great activists who made it happen. But you go to City Hall, you sign up. I think you have to sign up before 2 o'clock. You have to come back at 7 o'clock, and you have 3 minutes to give a talk. So I would love for anybody, to help organize those public comments about just how bad smoking is for your health. And then, as we get closer, about like some certain policy that they can help pass. Because I think they're probably going to be a little confused when I bring this legislation to them. So number 2, so that's smoking. It's the number 1 priority, so I spent the most time on it. Number 2, in no particular order, cars are a public health threat. So for 2 reasons. One, they kill 50 to 100 people in Cleveland a year through either motor vehicle on pedestrian or on bicycle or car. And they are the number 1 contributor to air pollution in our region. So everybody, wants to blame Steelyard and all these places, but again, those places are permitted. We regulate them. We're in there, surprise, inspections, all that kind of stuff. Cars are the problem. So what are we doing about it? There's something called transit-oriented development, which is getting rid of parking minimums. So now when you want to build like really cool housing and stuff like that in the city of Cleveland, you got to build like 3 gravel parking lots next to it. We're gonna get rid of all. And number 2 is bike lanes, infrastructure, all the things that we can do to help support multimodal transportation. So you might think, what can I do in those things? Well, it might be testifying, it might be just showing up to the meetings, it might be just reminding city council that this is a health issue. But anything I can do, I will do to support that. Gun violence, number 3. We lost 160, 170 people last year in the city of Cleveland to gun violence. Violence reduction efforts is not just a public safety thing, obviously. There's a recent amazing randomized trial that got published in, I think in JAMA, that showed that in neighborhoods with abandoned or boarded up homes, different blocks are randomized to interventions, improvements of those homes, or not, or just leaving them alone. And the neighborhoods, the micro, blocks that got the intervention, they had a 12% reduction in crime. So it's stuff. Well, this stuff. It's broken windows theory. It's stuff but it's really, that's the public health approach to gun violence. Number 4 is opioid overdose deaths. So we lost. You've heard all my numbers so far. We lost 350 people in 2021. They're still calculating numbers for 2022 to drug overdose deaths. Put that in perspective, I think in the city of Cleveland, there were 1,600 deaths total. And so, half of those use natural causes, cancer, heart disease, things like that. Much of that caused by smoking, of course, not all. And then number 3 up there is drug overdose fatalities. So the work we need to do there is, so I would have said, a couple weeks ago, everybody needs to get their X waiver, but now you don't need your X waiver. It's so great to be able to prescribe Suboxone, which is never needed to treat 5 people. You treat 5 people for 1 year, you save 1 life with a medication called Suboxone that hopefully you're now starting to learn about in med school, but for years, was neglected. But as a region, we need to do it a lot better on just a lower barrier to Suboxone, which is the treatment, and methadone. 2 methadone clinics in the city of Cleveland. They're both waitlisted. And so hopefully we'll have more Kates in charge of that. Fortunately, we have in charge of that. Who's that? Federal government's in charge of that. Well, yeah, but we're gonna help. We're gonna work. Narcan availability is a big thing, but Cleveland is like way ahead of a lot of our peers in terms of Narcan availability. And there's more we will continue to do and that we can do, but it's fairly widespread, which is reassuring. All right, let's see if I remember them all. Gun violence, poverty is my number 6, so we're gonna have to do there. Oh, that's gonna kill me. Let's see. Opioids, cars. I knew I should have written notes. That's all right. We'll just skip to poverty and I'll think of it. So poverty, is the obvious one, and that's basically the main reason that Cleveland is where it is, because of structural racism that created entire neighborhoods that were predominantly Black, and the Black-white wealth gap due to the long list of different policies is $1 to 12 cents. And so entire neighborhoods were basically impoverished and just toxic to long lives. And so poverty, we can fix poverty. So City of Cleveland, and we have levers to fix poverty, creating paths to community wealth, to generational wealth. So does that, how do we help people stay in their home if they own a home? I remember the other one, lead. So how do we help people stay in their home if they own the home? How do we help people buy their first home if that's the wealth generation that we're going to emphasize? How do we end the food apartheid on the east side of Cleveland, where there isn't access to grocery stores, which not only supply healthy food that's affordable food, but also create jobs and community. And so, a couple big chain grocery stores just left from Collinwood and Central. So how can we create food co-op grocery stores to help support generational wealth, jobs, all these sort of things, and healthy food access? So we're exploring anything we can. And then, of course, universal basic income is something that we're going to be a pilot city for. But it's not a big pilot, so it's not enough. So we got to keep going on that. So that's poverty, and then lead poisoning. It's been a $120 million investment across the city called the Lead Safe Coalition that is meant to help make homes lead safe that are very obviously lead poisoning, and you can spot them from the street. Just any house that's built before 1978 with peeling paint is full of lead and can poison kids, cause irreversible damage. And we're going to build as many new homes as we can, whether it's houses, apartments, condos, townhouses, every type. There's an entire continuum of homes that people need. And you all, you experience this when you are looking for homes in Cleveland Heights. There's a huge crunch, and it's hard to find a nice place to live, even as a med student. So we're trying. Takes a long time to build homes, apparently. Frustrating. So those are the 6 things, and you notice that there are a bunch of things I left off, but I think if we tackle these 6 things, and I think they're very much in our power, that those other things will get better. And there are a lot of good partners working on those other things too. We think these are our unique 6 areas where we can really make a difference. So smoking, I need your help. A couple different ideas, and with that, I'm gonna stop and see how we did on time.
Good.
Right.
Okay.
Thank you. All right. Oh.
Yeah.
Okay, we're gonna start at the back of the room. Any thoughts, questions?
Shannon.
Oh, there, I see a hand.
Yeah, I have a question. Yeah, thanks so much. That was really informative and educational. One thing I'm wondering is going from working at Metro, which county, like I guess non-government, to working in government, how have you noticed the, I guess, efficiency of what you're trying to do, whether it's quality improvement or as things change?
Listen, working in any hospital will prepare you for inefficiencies. You got nothing to worry about. But yeah, so Metro is government, kind of.
Yeah.
And no, it's a great question. So Metro, 8,000 person organization, employees, and they're like 6 or 7 vice presidents, and they're not always aligned. And this is not a Metro thing. This is any organization of a certain size. And so there are always, be these little fights and these little things. And anytime you want to get something done at Metro, and this is true in San Francisco, it's true anywhere. You got to pick your battles, because you're a doctor. When you speak, people are going to listen. So if you speak all the time, people are going to, start to drown it out a little bit. So you got to pick your battles, and so I would always have like 11 ideas I was trying to kind of push forward at once. And it wasn't always the right time for ideas 7 through 11, it was like, all right, we're keeping this one on ice until like the right vice president comes up with that as their idea. And so then it was a matter of like, all right, which vice president can I get to kind of champion that sort of thing? It's called, finding executive sponsorship. All of that prepared me really well for the city, because now I got, 17 council members. I got, our cabinet is 20 people, like the mayor's cabinet. And everybody's got different ideas. I mean, there's one boss, but he, you've seen him speak. I mean, he's very supportive of everything. And so he's not, cares certain, powerfully about certain things, but it's just, it's finding the balance. It's picking your battles. It's having that prepared memo, when you're ready to go, just a one pager. So someone can read it in like a minute, having the elevator pitch ready, and just having more than just one cause, I think helps a lot. So that you're ready to kind of jump on any moment. So the mayor is just rolled out or is about to roll out like the strategic priorities. There are 10 strategic priorities that they drafted for us and they showed in cabinet. And I'm not gonna be able to list them all, but health wasn't one of them. But population growth was. And I was like, oh man, this is bad. Like this is gonna go badly if anybody sees this, I'm talking about it. So don't tell them. So I raised my hand, the 20 people in the room, I was just like, it's, a dangerous thing. I was like, that's not going to go over well. Like, you want people to come here, you better fix what we got, and he's like, all right, good feedback, put a flag in it, and so then I go circle, I'm like freaking out. I'm like, oh, this is going to be bad, so test a couple vice presidents, all right, what do you think? What'd you think of that? Oh yeah, glad you spoke up, but I'm not speaking up, all right. So then I have my one-on-one with him, give him the memo. I usually have like 7 agenda items. I only have 1. So this is a big mistake. And he's like, oh, I'm totally there. He's like, I was going to give you the same article that you're giving me. This article by Richard Pipperdine. You remember Richard Pipperdine? It talks all about quality over quantity in terms of growth in Midwest cities. So he writes an email right then, changed. He was like, all right, so now it's health. So these are going to roll out. And not only is health going to be one of the priorities, but ending food apartheid was on there, ending green space apartheid. I mean, it's good. And it's just like having the memos ready, being, filling out the SharePoint and that kind of stuff. So, yeah, thanks. Question.
Thank you.
Yeah.
All right. Anybody else?
We just had a big new development here in Cleveland Heights, and one of my biggest concerns is they put in enough parking so that when I want to go down to, what was the name of the bar? Night Town,
Yeah.
that I can still be able to park there.
Yeah.
Can you explain again what, and I understand that that's not necessarily the most important thing to do.
Right.
But can you tell me what you were thinking of in terms of how regulating parking for new development?
Yeah, so
vehicles.
what we need, which the idea of transit-oriented development is building density on high transit corridors.
Okay. Yeah.
So people need to live where it's easy to get to. We don't need more jobs in Solon, where it's impossible to get to by public transit. We need them on high transit corridors. Parking minimums create the situation where you build housing and then the next, 3 lots have to be parking lots. So you lose density, you lose the ability to density. Any cool neighborhood in any city, any coveted neighborhood across the country, it's hard to park. And so hopefully we'll get to the point where it's hard to park at nighttime. That's the goal. And that's the case. So we're gonna have to make city council because they're gonna say the same things. And it's gonna be a thing, but it's like, it's okay.
It's already been.
I know.
Oh, great, good. It's hard to park there. Yeah. Well, Cleveland Heights has all sorts of weird parking stuff. I'm still mad at them. All my parking tickets are. Yeah, but
Parking all through COVID.
yeah.
Still have.
Yeah. Well, that's good. Yeah, I saw someone in the back and then
Over here we had, Lauren had her hand up. Or was there somebody back there?
I had a question, but I could go next.
Go ahead.
Okay, so my question was in terms of like how you as like a local public health organization interact with like federal and state organizations. So for, every issue that you mentioned, there are initiatives happening at the state and federal level to tackle those same problems. So do you receive like funding and support from those like state and federal organizations and programs, or do they work independently of what you guys are doing?
Yeah, no, it's a great question. I mean, it's one of the big challenges with public health in the country is that it is it's a mess in terms of so the way it's set up now is state power, which is really tricky because, as City of Cleveland, we might want to talk to the federal government directly and, figure out what the heck is going on and not wait for like Columbus to filter it to us, which is how it goes now. And I'll give you an example. We had our first death from Mpox we're all set, write up a press release, City of Cleveland, is announcing this death. Ohio Department of Health said, no, don't tell anyone. We don't want the LGBTQ community to get mad at us. Like, yeah, I'm pretty sure that you're thinking about this wrong, and so yeah, it's really messy. So it's the same to Zane's question. It's this big game, and you just, build relationships as much as you can. But yeah, the state gives us a lot of our grant funding comes from the state. We've got a couple of federal grants as well. We are lucky enough to be part of a coalition called the Big City Health Coalition. So I get to hang out with 35 other directors of public health from other big cities across the country. All those cities, to be in this elite group, you have to have a population of over 400,000 or have had a population. So they don't want to kick anybody out. So we're the latter. And so yeah, I got to hang out with those folks. So that's kind of a lobbying group too, where we got to meet with the CDC directly and with the HHS director directly. And when people come through Cleveland, they don't think to like reach out to Cuyahoga County's health, they reach out to Cleveland's health. So that's been good. But yeah, ODH, there are some really good people there, but they're a tough group to work with, but we have to.
Lauren had her hand up and I know. Okay.
Over here.
Yeah.
Hi. Thank you so much. Your talk is so inspiring. I guess I have two main questions if I could ask you. My first one is, it sounds like over the course of your career, you've been kind of building towards an ultimate goal of improving community health and public health. So my question is, what skills do you feel like you learned along the way between your fellowship and med school and everything that you feel like are serving you well in your current role for a student? Think about.
Yeah, sure. So it's hard to list just a couple, but I would say, number one, like I do not feel like, I don't ever want to feel like I'm done learning new skills. So at some point in my life, I started reading like different leadership books that you see in the airport bookstore. They're really good, So I'll point out two things, I guess. So one, when I was in San Francisco doing the clinic practice improvement work, one of our clinics was having a problem with communication from when someone checked in at the front desk to notifying the folks in the back. This continues to be a problem in almost every clinic, right? And so I said, all right, I got some ideas, I said to the medical director and the nurse manager, I said, let's meet, talk about this. And so I said, okay, when do you want to meet? All right, Friday. I'm a med student at this time, doing this year off. And so I sat down. And the medical director staring at me, the nurse manager staring at me. I was like, all right. And they're like still staring at me. I was like, oh yeah, so I thought we'd brainstorm about this stuff. And we started, it took a little bit. And then afterwards, the medical director of this clinic, small clinic in Bayview, San Francisco, pulled me aside. And he's like, never, ever lead a meeting like that without an agenda. Like it doesn't have to be, but like send it out in advance, like bring something, bring the memo, and don't ever do that again. And he was so kind about it, but like radical candor is another leadership book that you go through. So it was just like he didn't hold anything back. Like it was clear to me that like he meant nothing but respect, but like there was no sandwich. Sandwich is bad, right? Like there was just don't do that. He's now this guy's Mark Galley. He's the head of like health for California. He's a really cool guy. But anyway, so that's one. And then, number two. Number two. So in medicine, so as a resident, I think an intern in medicine, anytime you call a consult, it's like this fight. I don't know if you guys have experienced that yet, but it's just, you got to fight. So I called this GI consultant and was like, hey, this guy's bleeding, out of his butt. Like it's a bad situation. We need you here. And he's like, no, you don't. You didn't do this, that, and the other. And I was like, yes, I do. And I got really mad. And we, argued back and forth. And like, it really hurt me. Like, I was like, oh, I'm such a nice guy. Like, what's going on? And so I read this book called Crucial Confrontations, and which is great. And it was like when emotions run strong, opinions differ, and the stakes are high. Crucial conversations. And well, yeah, the follow-up. There's a follow-up crucial conversations, but you're right. Yeah. So, yeah. And it's just been, checking your own pulse and like taking a step back and like, oh, this guy is like really like, I don't need to get pulled in. It's not about winning the argument, right? All those things. So I would say, those two things are, I'll leave you, with that. That has have been really helpful for me. And still, you can still, anybody, we're all human, we slip in that. To be able to, at any point you're in a conversation with someone, to be able to pull yourself out, and recognize that you're in a thing where someone's trying to win an argument. Like, winning an argument is never the right thing to do. So, yeah.
My second question has to do with being an MD, and how do you feel like that informs your current role? And do you think that's necessary for your current role? And how do those things intersect?
Yeah, thank you. That's a great question. I was definitely initially felt like an imposter, and which is healthy. Hopefully, you all feel like imposters at all times. But no MPH had worked, the COVID stuff and had done the San Francisco stuff, but didn't have the kind of the classic public health training. So I was feeling really insecure about that. But got a really nice note from Scott Frank, who was a health director for Shaker Heights for years and years, and it was just like, like this is monumental, welcome to this group. And that made me feel a lot better. But I think now I'm not practicing medicine, and so again, sort of feel like an imposter. So I think it's a tricky balance, but I think the training, the primary care specifically, and OBGYN will count you. I think the stuff that we see, staying humble, but like feeling like we've got a good lay of the landscape in terms of the health problems of Cleveland as a result of that experience.
Okay, go ahead, Pat.
Oh, sorry. Yes.
Hi, I'm retired as a family physician, but I'm on the city council in East Cleveland. As you're undoubtedly aware, whatever problems Cleveland has, most of them we have worse.
Yeah.
And I'm not even on our health and safety committee, though I have expressed the interest. At any rate, one thing I would really like from you is a copy of all your proposed legislation. Because
Great.
if anything that you can do, we can make it like quitting smoking. Okay, if Cleveland quits smoking and East Cleveland doesn't, that's not good for either one.
Right.
And if we can both do it, of
Great.
course, that would be
Okay,
better.
let's do it.
And obviously,
You're the
all-
council
all the
champion I've been
rest of
looking
it.
for. Yeah. Okay. Great.
Yes.
Thank
And
you.
I'll hand you my card.
Great.
and I don't
Thank
have
you.
it.
That's wonderful.
So I love that. Can I ask a question about the 6 points?
Yeah, sure.
Okay, so,
Now that I remember them, all, yeah.
yeah, love that, 5 out of 6 are primary care focused. That's awesome. How is the city of Cleveland planning to support primary care for their citizens? So not to mention the kind of disaster that is Neon, that has lost, if any of you are familiar, this huge story, lost the city tons of money investing in something.
No, it hasn't. We haven't given them any money.
Okay, well,
We have it sitting there. We don't know what to do.
yeah, it's like a big problem, right?
Yeah.
So you're a busy primary care clinician and you have a
I
lot
can
to
explain
do.
the story. Yeah.
Yeah.
I need to explain the story.
Yeah, sure. Go ahead. Yeah, no, absolutely. Yeah. So yeah, haven't forgotten my roots, primary care. Granted, the solutions for primary care, need to happen across the globe, the universe. So it's but what can the city do? So the Neon story is the city council, as they were leaving, the former members, they passed this legislation really quickly to give $2 million to this FQHC called Neon. Turned out Neon was paying their CEO, who nobody had seen in like years, like $600,000 a year, and had given him like raises during the pandemic and all sorts of bad stuff. And so and then it turned out that the councilman who pushed the legislation forward was doing all sorts of corrupt things. So big problem. So the legislation passed, but anytime legislation passes, it's still up to the city to administer. So we haven't given them $2 million. We haven't heard from them. We don't even know who's on their board. We don't even know who we talk to. And nobody has to give me a name. That's okay. So, there are a lot of different things we can do with that money, and and probably shouldn't talk about all of them, but don't get me started. But yeah, I mean, we want to, I mean, I think we have a couple different things. We can highlight the problem, and peer pressure the healthcare systems to invest in primary care in the certain areas that, clearly are lacking in primary care. We can use our, Cleveland still carries a name throughout the country. So us going around saying this is a big problem in Cleveland, I think can make a difference on the federal lobbying station. We have federal lobbyists, we have state lobbyists. We know DeWine, says he's really interested in investing in primary care. Neomed has done a great job of activating that connection, I think. They check all the boxes, in terms of rural Ohio and primary care. So I think we can continue to leverage that. But open ideas.
Maybe like, I don't know, universal healthcare for city of Cleveland citizens.
Yeah, San Francisco did that.
Public option.
And San Francisco is the richest city in the country, and they barely did it. It was falling apart. And, if not for Medicaid expansion. So the city's in no financial shape to do that with our population declining, every time we check. But maybe the county.
Love it.
Yeah, but we'll see. I think there's a lot of work to do there. We still need to shore up our systems that exist, for folks with Medicaid right now. So I think we got a lot of work to do. We got a lot of work to do.
Thank you.
Yeah, thank you.
Any other questions back here? Yes.
I'm wondering, how can the healthcare systems in Cleveland support public health better? How can they support you better?
Yeah.
How can you partner with those systems?
Did everyone hear the question? Okay.
Yeah, so I the CEO, the new CEO of Metro Health reached out for a meeting, met with her last week. First thing I said was, hey, you're the only hospital CEO who's reached out, to meet with me. Good job. So as rough it is as it is at Metro, like, you've got that going for you. And I really am optimistic about her leadership. But we came up with all sorts of ideas. I really want 2023, the focus to be smoking. But lead poisoning, the issue, we still are not testing enough kids. And granted, we are shifting our strategy as a city to focus on testing where people live rather than waiting for, kids to be used as canaries in a coal mine, for the reference. But there's huge opportunities to help with anything clinical. When the Mpox vaccinations came to our department, coming from where I came from, I said, all right, we need to give these right away to the healthcare partners. Our healthcare systems need to have these vaccinations to be able to vaccinate the community, because they're just much better equipped for a large scale vaccination operation than us with our 1.5 nurses. Cleveland Clinic and UH held on to their vaccines and said, oh, hold on, we got to get our patients. Metro Health took them a little longer, and it's sort of my fault because that would have been my job to kind of roll that out. But they, as soon as they got it up and going, which only took a couple weeks, but as soon as they got it up and going, Michelle Hecker, it was everybody can sign up. And it wasn't like you got to go to this website. It was like you call, you walk in, all that stuff. So it's for the community, right? And so that's the conversation with the healthcare systems. And that's what with Erica Steed, it was like, we don't ever want to hear about your patients, because this is for the people. So that's, I think, the overall kind of spirit that we're gonna. And how much can we really do? Probably not much, but like, I think, I'm gonna pretend like I can do a lot, and I think I can. Yeah.
The reason for childhood lead poisoning in Cleveland is different and worse than it is in Flint, which has gotten all the attention.
Twice as bad.
Right. We have other cities in Ohio that have housing stock as old as Cleveland, and other cities in the nation. And I don't know. Can you tell us how Cleveland compares with others? And if it's worse,
yeah,
why?
We're the worst. The reason is poverty, structural racism.
So we're talking about failure to deal with an old housing stock.
Yeah.
There's other cities start with an old housing stock.
Yeah.
Ours is not maintained, so it's worse. Is
Yep, yeah, and so basically, structural racism through redlining said, these neighborhoods are for Black people. Black people are really poor. We don't want any money to go into these neighborhoods. They're gonna continue to live in these, we're gonna not invest there. They're gonna be higher traffic fatalities, higher rates of lead poisoning, higher, all these things. Yes, and yes, yes.
I'm sorry.
And then yes, yeah, sorry, because you were following up on that, huh?
Oh, yeah, I
Okay.
was following up on that a
Okay.
bit. It seems like, oh, that reminded me, it seems like of the 6 things you listed, seems like all of them go back to poverty.
Yeah,
Essentially,
sorry,
right?
I know.
So without tackling poverty, so hard to tackle the rest.
Right.
Can you tell us more about, I want to hear a little bit more about the plan. that
Yeah,
was
sure.
there.
So, yes, and you certainly, right. And this thing, a little pushback I got on tackling smoking was like, oh, now you just beat up poor people because they're smoking, sort of thing, and all that stuff. It's like, all right, well, I could do that, or I could say, we're not gonna do anything because poverty is this complex thing and it'll take decades to solve all that sort of thing. And the political will to solve poverty doesn't exist throughout the country and all that sort of thing. So we can't do nothing. And we can do something. I mean, we can fix smoking. We know we can. Any city that's passed this flavor ban, 22% reduction in smoking rate. When people are asked if they want to quit, many of them do take you up on that and they will quit. The medicines work. I mean, and, you just got to keep trying. So that's the case with smoking. That's the case, with lead poisoning. It's like we've got $120 million. We can fix this problem, the housing stock. We can do transit-oriented development. We can emphasize our multimodal transportation infrastructure. So while we're trying to fix poverty, we can do all these other things too. Yes.
Yeah, I was gonna make a comment very similar to that, regarding lead poisoning, because in the intersections between the 6 different things are so great. And lead poisoning is so central to poverty, but lead poisoning reinforces poverty with the cognitive deficits.
And violence,
and with violence,
Yeah.
with gun violence, it also impacts
Yeah.
that. So with the resources and, with the plain dealer doing as much as they could for the last 10 years to try to wake people up to this.
Yeah.
And now with the Lead Safe Coalition and some financial resources, what are the barriers now to actually getting something done the same way that other cities like Rochester,
Yeah.
for example, has made a huge
So
impact?
we're on pace with Rochester. We started much later, but we're, in year 2 or 3 of this, and when they were year 2 or 3, they saw a similar trajectory. So our lead poisoning rate is getting better.
Mhm.
It obviously needs to get to 0, but it's at 8.9, from 12.5 from 26 before. So it's happening. I mean, the main barriers right now are the same barriers that are impacting every part of the economy, which is labor shortage.
Mm.
In terms of having skilled contractors to do the work.
Testing.
Yeah, but it's happening. I mean, the city wasn't the best partner in that, previously, obviously, and so a renewed engagement there. The county turnover has been really helpful for us because we're completely aligned. Budish and Bib, we're barely talking. But Chris Renane is like everywhere. So that's helped a lot.
Yeah.
So I think
Because
we're
right here in Cleveland Heights, we have the same problem with an aging.
Yeah.
Housing infrastructure. Most of the houses are well before 1978.
amazing. We all made it out alive, huh?
Yeah. Shaker too.
Yeah. But yeah, so things are happening, but it's just nobody's satisfied with where they are, but we are seeing progress.
Just like along those lines, problems are very interdisciplinary. Do you interact with the other departments, housing, education?
Yeah, totally. I mean, most of them are other departments stuff. I just show up, say, hey, I'm here too. Yeah, no, so yeah, I mean, it's relationships are everything. Building housing director is incredible. The planning director, Joyce Wong. If you don't follow her on Twitter, you should. She's incredible. So sustainability, environmental justice director, Sarah O'Keefe, incredible person. So we all hang out. It's good. And it's a matter of sanity preservation too, because the work is hard. So you find your peers and support each other through the same challenges.
Yeah, so you were talking about like lead poisoning and also creating like, I guess a transit oriented like structure. And like you were saying, these areas tend to be the cooler areas, which would increase rent prices, increase property values. I guess how is the city of Cleveland working on making sure that it doesn't price out the people that are in these neighborhoods?
Yep.
It doesn't like, create
Yeah.
gentrification that, you know, is more, it doesn't create better quality for the people who actually live there.
Right. Yeah, I mean, that's how you do it. You keep talking about it, having awareness. I mean, investing in people so they can stay where they are, you know, in their homes, so that their homes don't get flipped, you know, the second people leave, right, that sort of thing. I would say, you know, Cleveland, given where Cleveland is, like, it would take a lot of gentrification to displace, you know, people. And so, what has happened in like micro neighborhoods in Cleveland might happen in more micro neighborhoods in Cleveland, but overall, like, we're not going to be San Francisco and New York City, you know, so we can rest assured in that, that there might be some gentrification, but what we would think of it as more of what we need is economic diversity, you know.
One thing we're talking about is capping property taxes in neighborhoods where there's development going on.
Yeah.
And there's resistance, but
Yeah, and you know, we just did our whole property tax thing where there were just all these, you know, Ohio City and Tremont and stuff like kept being tax free for 15 years, and so we stopped doing that and or we're phasing that out and spreading that across the city to make sure that, you know, that sort of thing doesn't happen. But right, because whereas like, right, your neighbor in poverty might be paying more property taxes than a brand new condo owner, you know, through a tax payment thing. So we got rid of all that.
Yes, sir.
You mentioned experimental with universal basic income. Can you elaborate on that or what you were thinking there?
Yeah, there's all good questions, by the way. Thank you. There's I think it's like 100 city pilot that's going on, and Cleveland's going to be in there. And so I don't know the exact timeline of when that would be. And one of the challenges with universal basic income is this concept of a benefits cliff. And so you give people money and all of a sudden they don't have health insurance. So you're like, you know, which is like really crappy, you know, right, exactly. Because the last thing we need is to, you know, decide, you know, oh, you can't have money, you know, this is up to us to decide. So we're trying to work through that. And I think all the cities are. I can't remember. Some big foundation. Yeah. Yeah. And some of it probably still has to be raised, but there's some, it's like a big venture capital thing nowadays that people are excited about. Which I think it is really exciting, but there's, you know, all these complicated parts to be worked out.
Lauren had another question?
Yeah, I guess, sorry, so many questions, but really great conversation.
It is.
I guess my question is, how do you determine what your priorities are gonna be? You kind of, it seems like, apart from these 6 priorities that you're working on right now, you kind of emphasize having an agenda. So in your career and in life, do you have any like general rules that you use to say, this is the direction that I'm going in, this is what I'm gonna focus on, when I'm sure you have a lot of opportunities and a lot of different ways that you can go?
Yeah, that's good. I mean, I would say with these 6, a lot of workshopping, you know, just like a stand-up comedian, like you go and try out your stuff. You know?
Are you trying it on other people? Like
Yeah.
people you know?
Oh, yeah. But then at a certain point, like having conviction really helps, you know, saying like, look, this is what's right. This is what we've got to work on. As far as, you know, other agenda and ideas and things like that. Yeah, I mean, I think a team effort. It's a team effort to get there. A lot of networking, you know, and not losing those relationships that I've built through my career.
Do you rely on your mentors to
Absolutely.
like help you
Absolutely.
like workshop ideas?
Absolutely.
along the
Yes.
way?
Absolutely. Yeah, and then, you know, that was one of the hard parts about this ship too, is like I was, you know, in a hospital system, you've got this like built-in hierarchy of kind of mentorship. It's a big emphasis, right, throughout, you know, med schools and departments and hospitals and things like that. So, out here, the mayor does not want to like sit and like check in on how I'm doing, He's a really nice guy, but that, he doesn't have time for that. And so that was one of the risks, but grateful for, this supper, I will shout out, I should have shouted out earlier, but when I first came here, back to Cleveland in 2015, 2016, I was here every month. And then my kids started, growing like memories and stuff. And I figured more time with them, but something that Jim Isaac said here really stuck with me, and I'm sure Jim's been, or you guys met him, and he said, in the life of an activist, it's not always going to be the time for you can always step back, spend time with your family, do what you got to do, like the work will still be there. And so I, really was grateful for that, which is a total segue from what you said, but just in terms of mentorship. So you find it, the mentorship's out there. It's really valuable. Thank you.
Well, I really want to thank you, David. This has been great, really great.
Thank you.
Yeah.
Appreciate it.
Now, we had a couple things we wanted to talk about before we all adjourn tonight, and then we'll encourage people to stick around and finish the desserts and talk as long as you like. You don't have to rush out. We want to float some ideas for our upcoming suppers, and we know we have, there's going to be a big initiative around abortion that we're probably going to focus on in an upcoming supper very soon. So Ken, do you want to start, or how do you want to do it?
Well, do you wanna talk about the reproductive rights?
Right, so-
Initiative first, and then.
Right,
then
and
we'll
then
get to
Nancy's secretary.
Yeah, Colin's actually on our team too.
Oh, right. Okay, so maybe, Colin, do you want to explain for everybody here in case not everybody, I don't know, is everybody up to speed on what's might be happening with the ballot initiative? Yeah, Colin, you want to summarize it? Or if you're not prepared,
Summarize, like, I work with Ohio Physicians for Reproductive Rights, and Colin, of course, us too. Everyone's welcome to be a member. Our primary goal right now is we're working towards a constitutional amendment to the state constitution protecting abortion rights. And our goal is to get it on the November 2023 ballot. So all of our efforts right now are focused on making that happen. We actually had our very first training session, probably like an hour ago.
yeah, tonight, right?
Yeah, so, yeah.
And you got one Sunday night, right?
Sunday too, there's going to be more.
And it's training for how to circulate petitions and get
Exactly.
petition signers, right? On this issue,
Mhm,
right?
That's correct.
So yeah, go ahead, Colin.
I was gonna say, I think one of the biggest ways that us as medical students can help right now is to utilize our resources with having campuses, other medical students, the access that we have. Even with like our undergraduate experiences or graduate experiences, if that was in the state of Ohio. But using those resources to gather signatures for the group, because I think the number is like 800,000.
Eventually it will require like 403,000 eventually, but we have to double it because we're probably gonna double it again, so.
And they have to come from like each county, correct?
Okay.
So the other big thing that we're waiting to see if they're really going to do is to increase, the legislature introduced a measure to make a supermajority requirement for passing ballot initiatives, specifically because they see this one coming down the road. And they've seen it pass in 3 other states, right? And always just under 60%. So they want to make it a 60%. So this will be, if they we'll know by February 1st, right? If it'll be on the ballot in the May 2nd primary, which no one will be paying attention to unless we're really organizing to try and defeat that. And it'll be the only thing on the ballot then, right? If it is, I think. Only legislature initiated things can be on the ballot then. So unless they come up with something else. And so that may impact also what people have to do. Yeah, Joan.
So my understanding is that there are 2 different groups in Ohio that are working to put an issue on the ballot to improve the whole reproductive rights situation. And one of them is the Docs group. I think that's yours, and the other, I think, are Planned Parenthood and other people. I don't know
Right,
the name.
Alliance for Reproductive
It
Freedom.
doesn't strike me as being the appropriate way to do it. It seems like we should fight together.
Yeah,
Can you comment on that?
I did not mean to be here to, do this, but I will comment on it because I'm here. We've actually been, in talks with them since the summer, and when the position group has formed. We've actually been talking since then. They were really busy saving the world because, they had to like help women get abortions out of state, focus on the election and campaigning for the election, et cetera. We were really, really focused on a constitutional amendment, to abortion in 2023. So we've been building a team since then, like a strategy team, et cetera. So our ultimate goal is the same. Like you said, they're also working towards a constitutional amendment. We're also working towards a constitutional amendment. There's multiple steps in the process. In the end, there's not going to be two amendments being voted on by like the citizens, like what you just said about the 800,000 signatures and what ultimately gets voted on. There's not going to be two. There's going to be one. Whoever ends up being the one will be the one that the other group backs up, I'm sure. But right now, the pace that we're working at, we will be ready for 2023, like our timeline is ready for that. The pace that they're looking at doesn't, make that uncertain. So that's.
Well, I don't think they've decided yet. That's my understanding. And they're doing trainings too, which is all for the good,
Yes,
you
it's
know?
all like I just, thank
Yeah.
you.
Pro-choice Ohio, I think what do they have? They call it ramp up for repro, you know? And so they're training people and
Doesn't the wording have to be the same?
wait, I think we're going to trust that all the parties involved are going to come together around the same wording and the same petition ultimately. And I know there's a lot of concern about security for people because it'll be a very emotionally charged fight. And I think they just hired the Ohioans for Reproductive Freedom hired Mission Incorporated, the same folks that ran the campaign, the successful campaign that passed abortion rights in Kansas. So, yeah, good. So I'm glad it's great that you guys, so we'll definitely, I think probably our next supper should be on this and what people can be doing about it and where the campaign is at. We don't have a date yet, but probably, by February 1st, we're going to know for sure, is this going to be a super majority or not? And if it is, that might speak to 2023 being the more important one because it won't be in effect yet then, right? Am I right? It would still be a 50%?
Say that again.
No, if it passes in May.
That's a primary.
If it passes in May, it will be in effect for the end of the year. The difference is that as of right now, it looks like they're not going to be able to do it because remember, the speaker of the Ohio House was elected by Democrats, even though he's a Republican.
Right, so
And one of the things he agreed on was that he was not going to bring this issue to the floor.
let's hope.
Of them going through now, the longer we wait, we keep waiting and waiting and saying, let's do it in 24, let's do it in 24. The more likely it is that eventually this is a majority bill will pass.
Right.
And it will be even harder for the citizen-led initiative to go through.
Right.
So that's why we're.
So I think we'll be looking at having a gathering by the end of February or beginning of March at the very latest.
Yeah.
But people should sign up for both groups' emails and keep these trainings would be great to do now. So you're ready to go.
I was just gonna add too, I think, right now abortion access, there's a stay in the court. And I think one of the big reasons too is hopefully that stays through the end of the year. So
I think it's probably gonna go through like June.
Okay.
That's what Dr. Gerkens, he owns like 3 of the 8 abortion clinics. He thinks it's gonna be like through June.
They'll go to the Supreme Court instead of,
So,
okay, wow.
it's not, he doesn't think it's gonna, we don't think it's gonna last the end of the year.
Okay.
So there could be a period of time regardless of not having any access.
But minimizing that would
Yeah, be better.
Boy. All right, so we wanted to just float a couple other ideas beyond this for upcoming suppers and see what people thought.
Yeah, so, well, I get a sense from the room that people are supportive of what Rachel said, which is that the next one we do should be on the reproductive fight. Is that correct? Is that anybody gonna shake their head this way? Or-
think so.
Okay.
Okay,
Thumbs up, all right. So, we like to have input from a variety of people in terms of what we should do at these healthcare justice suppers. And so in addition to that, the abortion rights, reproductive freedom that is now our next session. Here are a couple of things that I want to get a sense as to what you like or don't like among them. So another hot issue is the changes in Medicare, the rise of Medicare Advantage. For people who are familiar with this, the ACO REACH, the whole concept of value-based payments, bundle payments, etc. So Medicare is under very big changes. It was passed in 1965, and a lot is going on. So that might be an area of interest. A second one, and it's good to have Kurt in the room for this, is primary care. If you know, primary care, as we talked about tonight, has not flourished here as it has in other countries. What are the causes? What can be done about it? That's another potential area of interest. A third area of interest, and I don't know what they're teaching medical students about this, but there are some interesting things that may be in the AI world that will really change or have the possibility of changing practice. And I have a friend in Columbus who's AI, it's not board certified, but specialty certificate certified, who could be convinced to come
an
here.
MD.
An MD, right, a family doc. So those are three issues, and then another issue we've talked about, you know, David did a spectacular job tonight at talking about social causes of illness. But I think another more medical area that could be of interest is the unrolling of viral epidemics, because COVID ain't over, in case you hadn't noticed. And I think there's some science as well as public policy issues that could make for an interesting discussion. So those are 4 suggestions, and just see if anybody has other, you know, suggestions of things that you're really excited about or reactions to those 4. And we want to
Yeah, we
2
should
to 3
wrap up.
minutes. So anybody want to shout something out about what I just said, other than sit down? Any
You
thoughts?
are sitting down.
I know. Any thoughts about those 4? So Medicare, primary care, AI, ongoing viral epidemics. Any choices?
Or all of the above.
Certainly all of the above, but it seems to me that Medicare Advantage plans are steamrolling.
That's right.
And the ads that those of us who are of an age are getting all over the place. I presume because I am.
It's a privatization of social insurance. That's what's happening.
And it seems, I would put that high on the list.
So would I would like to hear that discussed.
Of course, we're the older crowd. What about some of the others?
I need to learn about it for my patient.
Yeah,
That sounds interesting, something I'm not too familiar with and would love to
right.
learn
Well, it's
about.
certainly going to have an impact on your future work.
And your patients.
Yeah.
Okay, any thoughts about any of the others, or should we just go with Medicare?
We don't have to map it all out right now, but
I would be excited to learn about preparing for the next pandemic.
oh, yeah.
Good.
Pandemics,
Pandemics. That's be great.
nods on that one.
I'm kind of worried that I won't be able to find a primary care provider when I'm older.
So I,
Yeah.
I like that.
You know
The
what?
primary care.
It's tough. Try finding a geriatrician when you get to be my age.
I know one.
Yeah. Very cool.
Okay, so
Well,
we've had positives for 3
yeah,
and we'll work it
the
out.
AI thing, I think we gotta think about a little bit, how to
Yeah,
handle that.
well,
Yeah,
hold on.
that's really terrifying, actually. Anyway, well, this has been great. I'm so glad you all came. Please come eat more dessert and schmooze and we'll be in touch for next time. I want to thank our student leaders for getting all the students here. Alan, Zoe, Gabby, Shannon.
I had a request for the group. I would like us all to stop talking about the United States as having a healthcare system. And I would like to propose the wording healthcare situation. I personally call it healthcare chaos, but I was looking for something a little more neutral.
It's not healthcare crisis, not healthcare chaos.
Yeah, good point, good point.
Fair.
Thanks. Hey, thanks, everybody. Thank you all on Zoom. Bye.
Home from study abroad. I pushed that down.